this lecture we'll be discussing renal pathology, that is, the diseases associated with the kidney and the upper urinary tract. In the first section, we'll review some basic anatomy and histology of the kidney, and a little bit about kidney physiology that we need to understand the diseases of the kidney. In addition, we'll talk about a few different congenital diseases of the kidney. Let's start by looking at a basic picture describing the anatomy of the kidney. The kidney basically serves as a filter for the blood. Blood enters the renal artery and progresses through renal arterioles and finally to capillaries, which end in glomeruli. The filtration of the blood occurs primarily in these glomeruli that are found in the renal cortex, which is in the outer shell of the kidney proper. The filtrate then filters through the glomeruli and down through a tubular system, ending in the renal medulla, where a series of collecting ducts join together and empty into the renal calyces. These calyces then join together to form the renal pelvis, and the resulting urine is released in the ureter and goes down to the bladder. Now, the main working part of this kidney then is the glomerulus, a histological picture of which is shown here. Now, to understand the function of this glomerulus, it's probably easier for us to look at this schematic diagram shown in this slide. Now, the important function of the glomerulus is to filter plasma, and it does that by having two tubular systems that are next to each other. One of these tubular systems is the glomerular capillary. The glomerular capillary contains blood. Now, the plasma, the water portion of the plasma, some of the electrolytes and some of the small molecules that are contained in the plasma are able to filter through a barrier into a different tubular system consisting of the parietal epithelium and the urinary tract system proper. Now, the barrier between these is a basement membrane. So the lining of the endothelial of the capillaries is made by a fenestrated endothelial cell, which allows a filtrate to pass through that through an intervening basement membrane and then into the urinary system. The urinary side of this glomerulus includes the visceral epithelium, which is epithelial cells which have foot processes abutting the basement membrane. So as the filtrate passes from the capillary, it goes through the fenestrated endothelium, it passes through the basement membrane, and then through the foot processes, or adjacent to the foot processes, into the urinary tract proper. And that then becomes the urinary part of the glomerulus, and that's how it functions. Now, we can see that in this EM picture here. You see the capillary lumen, you can see the fenestrated endothelium, followed by a basement membrane, and then the individual foot processes between which this filtrate enters the urinary tract proper. A closer view shows this tract with the foot processes, gaps in between them, the fuzzy middle part of the sandwich, which is that basement membrane, and then the fenestrated endothelium. Again, the filtrate passes from the capillary lumen through the fenestrated endothelium, past the basement membrane, and between these foot processes to enter then the urinary system. It then proceeds through the urinary system through a series of tubules in which certain things get reabsorbed, the urine gets concentrated, it ends up in collecting tubules, collecting ducts, and goes then to becomes urine. Now, one of the ways that renal function can be disrupted is with particular congenital disorders. Most of these are anatomic anomalies which people are born with. One of these is called renal agenesis. This is a situation in which the kidneys themselves fail to form. Now, if renal agenesis is bilateral, then there's no kidney function at all, and this is incompatible with life. Now, when the kidneys don't exist, that means that the fetus is unable to produce urine. The consequence of that is something that we call oligohydramnios, which means there's not sufficient amniotic fluid to protect the baby as it develops. A consequence of this is the baby sort of gets smashed as it develops, and develops what we call the Potter sequence. This includes Potter's facies, which causes a flattened nose, low-set ears, and a recessed chin. They may also develop hypoplastic lungs from congestion, that is, the lungs never fully develop in size and function, and they'll have defects in the extremities as well, again, that occur because of compression in the situation where there's inadequate amounts of amniotic fluid. Now, you can detect this on ultrasound simply by finding oligohydramnios, or the lack of adequate amounts of amniotic fluid in the ultrasound. If the renal agenesis is unilateral, this is usually compatible with life. The kidney that does exist undergoes a compensatory hypertrophy, and its function makes up for the absence of a kidney on the other side. These patients may over time, over a lifetime, develop renal insufficiency and progressive glomerular sclerosis due to the stress on this single functioning kidney. Now, another condition in which the kidney forms but not completely is called renal hypoplasia. In this case, this is a failure of the kidney to develop a normal weight, to develop the adequate number of renal calyces and lobes. And this can lead to progressive kidney failure as well. Now, there can be ectopic kidneys, meaning kidneys that form, but they're not anatomically located in the proper location. A lot of times what will happen is that these kidneys will develop in the pelvis. Now, this is usually not a problem because the kidneys function normally. The only problem that can develop is that the ureters have to pass through a completely tortuous path in order to go up into the abdomen and back down to the bladder. And this predisposes to obstruction of the ureters, leading to infection and pyelonephritis, which we'll talk about later on in this lecture. Another anomaly that can develop with the kidneys is what we call a horseshoe kidney. This is a very common finding, in fact, and usually has no clinical significance, so that it's usually detected at autopsy in somebody who died of a non-renal cause. What happens in this case is that the kidneys never fully separate, and so you end up with one kidney that's fused at the lower pole, so that has the formation of a horseshoe-type shape. Again, as I indicated, this usually has normal renal function. There is an increased risk of nephrolithiasis or kidney stones in these individuals, but they normally have no kidney problems throughout their lifetime. Now, here's a clinical vignette that's associated with a particular set of congenital renal anomalies. A 47-year-old male presents with what he describes as the worst headache of his life. We call this a thunderclap headache, one that occurs all of a sudden and causes incredible pain. He also says that he has some dull left flank pain, and he's had blood in his urine, or what we call hematuria. When you ask about a family history, he said that his father died of chronic renal failure, and his grandfather died of a cerebral hemorrhage. Physical examination reveals hypertension and abdominal masses in both flanks. What this gentleman has is what we call adult polycystic kidney disease. This is a relatively common disease with an incidence of about 1 in 1,000. It's caused by a defect in a gene on chromosome 16. In this disease, people develop bilateral renal cysts that damage the renal parenchyma and over time cause progressive renal failure. The first manifestations of these diseases are often in young adulthood, around ages 15 to 30, and it's inherited in an autosomal dominant fashion. The clinical features of this disease include hematuria, flank pain, urinary tract infection, renal stones, hypertension, secondary to lack of renal function, and secondary polycythemia, which is again from the excess production of erythropoietin by the kidney. Now, in addition to the renal defects, these patients may also develop hepatic cysts, which can lead to polycystic liver disease and decreased liver function. And they're also associated with particular type of intracerebral hemorrhage due to baryaneurysms in the circle of Willis. And so these people can develop these baryaneurysms, which can rupture and lead to intracerebral hemorrhage. This is what causes the worst headache of their life. Now, the normal course of this disease is a slow progression to chronic renal failure. You may be first detected in early adulthood, but may lead to complete renal failure around middle age, ages 40 to 60. Now, there's another type of polycystic kidney disease that we call juvenile polycystic disease. This, in contrast to adult-type polycystic kidney disease, this is an autosomal recessive disease, and it occurs usually early in life, leading to the early development of progressive renal failure. Like the adult form, they also can develop cysts in the liver and in the portal bile ducts, and this leads to congenital hepatic fibrosis. Now, the onset of this disease is variable. Neonates who present with this disease will have both renal and pulmonary symptoms and often die very early in life. Infants will present with renal symptoms alone, and juveniles, when it presents later in adolescence, they often will present with liver symptoms alone, leading to hepatic failure and variceal bleeding and so on and so forth. Here's a picture of what polycystic kidney disease looks like. You can see that each of these kidneys has numerous cysts. They're small, and they completely obliterate the normal renal cortex and medulla, such that you can imagine in this case there would be very little renal function left at all. Now, you can also have simple renal cysts. Now, these are usually single cysts that form in kidneys, and this is a very, very common occurrence. These cysts are usually translucent, they're filled with clear fluid, and lined by a gray smooth membrane. These membranes are composed of a single layer of cuboidal epithelium, reminiscent of the epithelium that you see in the urinary tract. Now, usually these are clinically insignificant, usually cause no clinical consequences whatsoever, except that a few people may develop microscopic hematuria as a result of these. Now, there's another type of renal cyst that's not congenital. These are called acquired renal cysts. These are cysts that occur in patients who undergo dialysis. Again, these usually have no clinical consequences, except there's a small increased risk of the development of renal cell carcinoma in people that acquire these cysts. And this ends the lecture on basic histology and congenital defects of the kidney.